Okay, so now we're going to talk about bioterrorism. Bioterrorism is chapter 13 in your Williams and Hooper. Does this to me every time. Okay, so bioterrorism. This is when we have an intentional release of certain pathogens that can cause harm to us, our livestock, or our crops. So it's something that someone's going to do intentionally that can affect all of us in many different ways. So the best thing for us to do is early detection, and how do we, and management is going to be the best thing, and how we can contain these diseases. So the emergency room is the most likely place where these people are going to show up. So when we start thinking about that, we want to start being very alert in our, emergency rooms, looking for people that are coming in with similar diseases. Maybe they that don't usually occur at a specific time or a specific place. Maybe they have certain manifestations that they're coming in and they're like, this is really weird. Where did this come from? Or they're occurring in a specific community or a specific group of people. So when we look at like food poisoning, sometimes, and I know that kind of a little off the topic there, but if you think about emergency rooms, that's one thing that we're always looking for, is similar people coming in with similar disease processes. So if we have people that come in and all of a sudden these people are coming in with vomiting, diarrhea, high fevers, and we're like, we have multiple people coming in, we're going to start asking those people, where were you? What were you doing? Were you at a restaurant? And so what we're trying to do is gather a similarity pattern. Where were the people that they could have came in contact with the same pathogen? And so we kind of try to backdate that. Usually our CDC becomes involved when it's something of that nature, just like they did with COVID-19. The CDC comes in and they're starting to identify, where did these people come from? Where did it start? Where did it go? And so that's what we're doing when we're thinking of bioterrorism. So there's different agents that people are going to use for bioterrorism. One is bacteria, viruses, and toxins. So those are the things that you're going to find with bioterrorism agents. One of the most common one that is a bacterial agent is going to be anthrax. It's called Bacillus anthracus, and there's 3 forms of it. There's inhalation, that's going to be the breathing one. Cutaneous, that's going to be on your skin. And then an ingested one, that's your gastrointestinal. Now, with anthrax, I know it sounds crazy, but if we're taking care of our patients, there's no isolation for them. It's going to be standard precautions. So it's not going to be, you have to come in contact with the bacteria, not the people that have it. That's why it's standard precautions. It is fatal if it's not treated. So we treat it with antibiotic therapy. Now that's why, recognition is going to be very important, that we recognize that very quickly. So if we get the inhaled version, this is, probably the most one that's going to harm the most patients, because it's going to be inhaled. So what they're going to present with is fever, cough, shortness of breath, muscle aches, headache. So if you look at these signs and symptoms, what other people present to the emergency room with the same stuff? Pneumonia patients, COPD patients, all of our patients are going to come in with some of the same symptoms. So it's going to be really important that we really start talking to these patients, start looking if there's other ones coming in with the same type of things. There is an anthrax vaccine if you're in a high-risk population. Prognosis is going to be poor if we don't figure out the treatment, if we don't figure out that's what they have. So treatment is just basic antibiotics that we have at our fingertips. Cutaneous is where it's going to be on the skin. So they're going to get these lesions, and they're going to start out kind of itchy. They're going to go into vesicular lesions. Then they're going to become necrotic, and they'll die, and they're going to form black eschar, and they're going to get fever. And the biggest thing about this, they can become septic. So we're going to treat them with the same thing that we're going to treat the inhaled with. The inhaled is probably going to be the one that we're going to use for bioterrorism. It's probably the most serious, because it is, the prognosis is very, very poor if we don't catch this early. Botulism. Botulism Botulism could become a biological weapon if it's aerosolized. Botulism is what we find in like canned foods that have went bad inside the can. We find this in the soil, but it's called Clostridium botulism. And it is probably the most potent, lethal toxin that we know of that is out there, because it's a neurotoxin. So it's going to affect your neurological system. And so what that is going to do, it's going to give you a paralytic illness. So it's going to start paralyzing your body slowly because it's going to block those neurotransmissions. It's a toxin that gets in between your neurotransmitters and doesn't allow that transmission to occur. This is not contagious. You actually have to breathe it in order to get it. So these patients are going to come in, and this is probably one of the most scariest ones that they're going to come in. They come in with this triad. Triad means they're going to come in with three things. They're going to come in no fever. Their mentation is going to be clear. They're going to know everything going on. They're going to know what's happening and everything. But what's going to be happening to their body is they're going to start getting symmetrical descending paralysis. So their body's going to start slowly becoming paralyzed, and they're going to know what's happening until it affects the respiratory system, and the respiratory system will paralyze and they won't be able to breathe. They won't be able to move. And so it's going to start just symmetrically paralyzing their body, which is very, very scary. And these patients are going to be like, I can't move my legs now. I can't move my hands. And then it's going to be, I can't take deep breath. I can't take deep breaths. So many of these patients are going to end up on a ventilator because it's going to affect their neurological status. So how do we treat that? If we know that's what it is, we can treat it with Trivalent. And what that is an equine antitoxin. So we're going to get it from an outside source. And what that does, it prevents the progression of the disease. It won't stop what's already happened, but it won't allow the disease to progress any further. Now, the biggest thing that we can do for these people is supportive care, which means that we have to support their airway, because as they start to become paralyzed, they might not be able to swallow. They might not be able to have a gag reflex. They won't be able to cough. And so we're going to have to do all that for them. So we're going to have to, intubate. We're going to have to, oxygenate them, make sure that they're getting what they need. This is not transmitted person to person. You actually have to come in contact with the botulism bacteria in order to get it. And we use standard precautions. So this is another standard precautions. You think about these biological weapons, you think it should be like airborne something, but a lot of these are not. They're just standard precautions. These patients have came in contact with it, but you as a healthcare worker did not come in contact with it. You're just taking care of the patient that has the results of the toxin. So, they would want to, if they've been exposed to it and it's been aerosolized, they want to wash any exposed clothing. They're going to have to shower if they've had any aerosol exposure, they're going to have to shower with a certain standard shower. So we're going to wipe down everything with certain bleach solutions and make sure that we're not getting it on anything else. Then we go to the bubonic plague. The plague has three forms. Bubonic, which has to do, if you look up here, it has to do with like lymph nodes. It's going to make your lymph nodes swollen and sore. Septic is where it's going to get into the body and it's going to start, it wreaks havoc on the entire body. And then pneumonic, it completely puts them into respiratory failure. So many of these patients are going to die of respiratory failure. Okay, so how do we get it? What is the plague? The plague is a Coccobacillus. It's from Yersinia pestis. It is caused by a bite from an infected flea. So the flea carries the plague, and then the flea bites other things. And it's direct contact, so you're going to have to get it from that direct contact. So there's three forms. We have pneumonic, that is in the lungs. So that is where they're going to get it into their lungs. Maybe they have aerosolized or they have gotten it into the air somehow and they are breathing it in. This is the most fatal form. This is the form that they feel like if there's going to be a biological attack, this is the form that they would use. So they would aerosolize this Eucereus, they would aerosolize Yersinia pestis, and they blow it out into the air. So it's the most fatal form. These people, if it's not caught, will go into respiratory failure within 4 days, and then there's not a lot of treatment that we can do for them. So when this person presents to the emergency room, they're going to present with a lot of things that look like other things that we know about. So fever, headache, rapid pneumonia, shortness of breath. So you can see where if they present with this in the emergency room, they might not be thinking about, the pneumonic plague. So it's important that as an ER doctor, as an ER nurse, that we have these in the back of our minds all the time, especially if you have 4 patients that walk in that have been in the same place, presenting with the same symptoms. So that's really important that you keep that in your mind. It's easily treated with Levaquin. Levofloxacin is what we treat it with. Now, these people do have to be on isolation. So they're going to be on droplet precautions until they've been on antibiotics for 72 hours. So they get that pneumonic plague in their lungs. It can be when they cough it out or they breathe or talk, they can breathe that out into those droplets. So they need to be on droplet precautions. Bubonic. Bubonic is a different one. These guys, this is where it gets internal, and it's a different form of the plague, but it causes swollen, real tender lymph glands, fever, headaches, and if you look back here at the picture, this is where it gets into the lymph nodes and causes the lymph nodes to swell and be very sore and tender. They will be in contact precautions because a lot of times these things right here will burst, and they will burst outside the skin and it will have the infection inside it. So some of these bulbules, we call them bulbules, will burst open and they will drain a bunch of drainage. That drainage has the plague in it. And so they're going to be on contact precautions until they're no longer draining. They will also be on antibiotics. And hopefully that drainage would not be infected after 72 hours. But I would just be cautious about the draining bulbules. Septic, this is, fever, chills, abdominal pain, DIC, which we're not going to really talk a whole lot about, but DIC is many times fatal. It's where the body just, because of the infection, starts to just spontaneously bleed. Gangrene, especially of those external digits and things that are farther away from the body. So that is the plagues. I would know the 3 types of those plagues and what they present with. Smallpox. We call smallpox variola major. We had smallpox in our country for many, many years, but we eradicated it in 1980. So nobody gets vaccinated against it in our country. So this is something that they could do in our country because many of our younger people have not been vaccinated against it. But it's really kind of low on what they would use as a attack agent. So it's not something that you would think that they would use. However, because it's so highly infectious, it is something that they could use to cause an infection. Very, very highly infectious. It is a public health emergency if smallpox comes back. Incubation is 7 to 17 days. This is going to be strict airborne precautions. So these patients are going to be on strict standard precautions, which is your tier 1. We're going to add our tier 2. We're going to add a contact, and we're going to add a airborne. So you're going to wear everything that you would go in to take care of these patients. So you're going to have your N95. They're going to be in a negative pressure room. They're going to be in a room by themselves. You're going to have gown, gloves, mask, goggles. Everything will be on to protect yourself from this. So smallpox, things that you're going to see: fever, headache, chills, vomiting, delirium. And again, they're going to present with this, but you're not going to know what it is until 2 to 3 days later when the smallpox start to appear. So that's kind of scary because a lot of people can present with all of these symptoms And it looks real similar to influenza. It looks similar to strep. It looks similar to a lot of things. And so then once the rash develops, then we start thinking, oh, I kind of got an idea what I think this is. So prevention-wise, there is a vaccine. We have a smallpox vaccine, so we can vaccinate them within 4 days of exposure. So let's say that we had a group of people that were exposed to it for whatever known reason. We can give them the vaccine, and hopefully that can prevent them from coming down with the disease. Treatment, it's supportive care. There's really nothing we can do for that. There's no antibiotics because it's a virus. It's a smallpox virus. So we're going to support them. We're going to make sure that their lesions don't get infected. And many times these smallpox get nasty and they get all over their body. They cause scarring. Patients can die. There is a 30% mortality rate for these people. We can give them medications for pain. We can give them medications for itching of the lesions. We might give them antibiotics to prevent any secondary infections, especially in those smallpox lesions. Then we move to Ebola or yellow fever. These are called viral hemorrhagic fevers. So these just cause hemorrhage to someone with whatever virus that they have. So symptoms, these guys are going to come in with fatigue, kidney failure, elevated temperature, and what's really going to be identifiable with this one is they're going to have internal and external bleeding. So they're going to come in with bleeding from their mouth, from their nose, from their eyes, from any mucous membrane. They're going to come in and going to be very sick, and they're going to have internal and external bleeding that we can't stop. Prevention-wise, excuse me, there is a vaccine available for yellow fever. So I'm thinking if you go to other countries that don't have good sanitation, or there's certain other countries that you go to that you have to have a yellow fever vaccine. So if you're traveling overseas to another country, usually you can get a hold of the health department and they will let you know what diseases are prevalent there and let you know what series that you need to get. So those are kind of things that we would want to do. Isolation precautions, they're going to be specific to what the disease is. Insect repellent, because some of your hemorrhagic and your Ebola, some of that can be spread from mosquito bites. So we got to make sure that we're preventing that kind of thing. Treatment, there's no cure for either one of these. It's basically supportive care only. So if we're doing supportive care, we're not going to do a lot of things that are going to cause them to bleed, because we know that they have these hemorrhagic fevers. And that is the end. If you guys have any questions, please let me know. You will have an exam. There is a quiz that will be over your bioterrorism, HIV, hepatitis stuff. Okay.